So this is for that microphone, and this is for the room microphone.
Which?
So this is for the online one.
So they're going to clip this to them.
So we just have to have them both.
Thank you, everyone. If I could have you take your seats.
Yeah. So
And welcome to our mainland guests dialing in. Thank you very much, and thanks for waiting. Again, thank you. We're very honored to have many of JABSOM and the Hawaii State Department of Health and speakers from all across Hawaii and the Pacific. And to help give us the tone, set the tone for the conference, which is really, again, creating sustainable partnerships to reduce cancer and NCDs in Hawaii and the Pacific. We thought that it would be good to have three very esteemed speakers start us off with our opening keynote panel. So our first speaker is our own chair of the Department of Native Hawaiian Health, which is the only Department of Native Hawaiian Health in the country in medical school. So we're very, very pleased to have Dr. Keawe Koholakula come and join us. He has a PhD in clinical psychology, and I said he's the chair of the Native Hawaiian Health Department. He's also deputy director for the Center of Native and Pacific Health Disparities Research here at the medical school. He's a licensed clinical psychologist and has clinical experience in behavioral medicine. His current research is many and is funded by the National Institutes of Health, and he currently works to examine biological, psychological, and social-cultural factors and their interplay, which affect Native Hawaiians and Pacific Islander health. And he helps to develop community-based and culturally relevant interventions. He has worked in the area of Native Hawaiian health for at least 18 years. And at this time, I'd like to welcome Dr. Keawe.
this is to all right. Mahalo. Avalina me ke aloha ia oko e nakanako iwi me nakanaka like ole mai ka moko ke awe a ka helelani, mai ka mona nui a Akea, mai ka Amelika, ka aina mamau. Aloha mai ka ako. That's a long way of saying good afternoon in Hawaiian. Were you getting me? Oh, I thought you was getting me. I was just telling someone in the back there, Bruce, that I was getting pretty tired of talking about health disparities. I get asked all the time to do that. So I'll try to make a little twist here today and end with some positive things to think about for all of us. But I'm asked to talk a bit about Native Hawaiian health and some of the challenges we face as contemporary Kanaka Māori. But before I do that, I'd like to set the stage, and I appreciate Dr. Ball's comment about our health is more a reflection of our zip code than our genetic code. The example I'm going to share with you further illustrates that. We're all familiar with the Titanic, right? Anyone in the room don't know the Titanic? That famous ship that sunk in the Atlantic. So if you look at the Titanic as a zip code, it has one zip code. Let's pretend it has one zip code. But it does have rules. Actually, I'll take that back. It has three zip codes. First class, second class, and third class. Think of the Titanic as a nation or a country with different social classes. And it has policies that guide the decisions that are made on that boat or that ship. So in a time of emergency, like a public health disaster, certain decisions are made about who survives and who do not survive, who has access and who does not have access. So if you recall the Titanic, where you temporarily lived on the Titanic determined your mortality and basically your morbidity. I'm sorry, your mortality. There on the Titanic, right? Do you recall where the third-class passengers were? They were at the bottom of the boat, of the ship. The second-class passengers were somewhere in the middle. The first-class passengers were at the top of the ship. Where were the lifeboats? At the top. So they had more immediate access. Well, were there enough lifeboats on the boat for everyone? There wasn't. And what was the decision this country had about who had access to the lifeboats? Women and children, but of what class? First class. So only a handful of first-class women and children actually died on the Titanic. Over 90% of them on the third class actually perished. And guess what? They were all white. They were all white. Whether Irish immigrants coming to the US, English, or Americans, they predominantly were white. So their race or ethnicity didn't count. Their social class did, whether or not they survived. So what I'm trying to do is rule out genetics. I'm trying to rule out those differences in individual choice because all of them wanted to survive, right? The third class wanted to live just as much as the first class. They could swim just as good or run just as fast to the lifeboats. The only difference was there's certain rules in place based on your social status in society to determine whether you died or not that night. That was it. So I'm going to talk a little bit about that and how it's playing out here in Hawaii, because I think the story is similar throughout the Pacific. And just in case you don't know who Hawaiians are, we are the indigenous people of Hawaii. We resided here prior to 1778, the year that Captain James Cook mistakenly happened to haphazardly come upon Hawaii. We represent a significant amount of the state's population here in Hawaii. This is important. In most countries, in most places where there is one dominant ethnic or cultural group or ethnocultural group, usually that ethnocultural group is the dominant cultural group or dominant group. Their values and aspirations are promoted in society, just like white Protestant values are promoted in the US, because white Protestants make up a majority of the United States population. What's really interesting here in Hawaii, where there is no one ethnic majority and where Native Hawaiians make up 25%, marry everyone else, so we're connected to every other ethnic group in Hawaii. If you add Pacific Islanders in there, we make up close to 35% of the state's population, to include Filipinos. But yet we don't enjoy a social status that represents our, that illustrates our representation in the state of Hawaii, unlike other places. That's interesting. It's very interesting. Something to think about. I'll come back to that. And going back to Hawaiians, we're so mixed up because we married everybody. But despite that, Hawaiians, regardless of degree of ancestry, 93% of them identify highly, and in some cases exclusively, with their Native Hawaiian heritage. So of course, Native Hawaiians today still value and aspire to live as Kanaka Maoli. And what the census tells us is that we're a fast-growing population. We are still the largest Pacific Islander group in the United States. A majority of the 530,000 plus Native Hawaiians live in Hawaii. And the good news is, by 2050, we'll double in our population size. That's great news. And we need to take advantage of that. It's the same for most Pacific Islander groups. We're the fastest growing population in the US, and I would assume growing pretty fast out in the Pacific as well. But we got to be careful. If we don't act today and do something to reverse the trend that we're seeing with chronic diseases and cancer, it's just more of our Kanaka Maoli to fall ill and die 12 years younger than other people. I don't say that to scare us, but I say that we have opportunity here with the increase in population. And it's good to see many students in the audience because it's going to be an increase in our younger population and it's going to be an increase in our older population, our kupuna living longer. And so, I like to look back in time, not to lament over the past or to glorify the past, but to look back and see what's a good baseline. We talk about health equity and health disparities, and we always use in Hawaii and in the US Caucasian as the reference point, or the measuring stick, if you will, as if they're also doing well. I always tell people when I travel, being American is bad for your health, even for white Americans, because white Americans die younger from cardiovascular disease and other factors than their white counterparts in Europe. So there is something about the American way of life and culture, stress, zip codes, differences in zip codes perhaps, that puts everyone, despite their ethnic background, at risk for earlier death and more disease. But just so happens that even in the US, there is large disparities between ethnic groups that we need to pay attention to. But there is something going on. But when Captain Cook stumbled upon Hawaii, this is part of the story across the Pacific, because he went all over the place. What he observed is up here on the screen here. he observed a very healthy, robust, thriving population. Population that, in his words, actually seemed to be free of disease and very much happy. Quite different from the picture the missionaries painted of us native Hawaiians back then when they came to Hawaii in 1820. They had a very different picture of us. But upon the first contact with foreigners, this is what Captain Cook observed in his men. He observed a very healthy and thriving population, a population that was not willing to be sacrificed to Pele, a population that was nimble, not obese, a population that was jovial, not depressed. If you look today, it's quite different for us Kanaka Maoli. Many things have changed that had altered that health and social status we once enjoyed. And I'll present some of that shortly, but just to show you how a lot of the social disparities are very much in line with our health disparities. We have over there the far right, or your left actually, obesity. The far left bar, the highest bar there is Native Hawaiians. Next is Filipinos, Japanese, whites, and overall state. As you can see, Native Hawaiians exceed other ethnic groups. And this is not the kind of exceeding we like to have in all of these indicators, as well as household income less than 20,000 and less than a high school diploma. And as you can see, we're also at risk for many things, and we die from these top heart disease, cancer, stroke, diabetes, and accidents and injuries more so than other ethnic groups. I talked a bit about how things have changed for Kanaka Maoli from the time of 1778 to the present. Up here are some of the things that change. I highlight these things to show how social events, changes in political structure, changes in social status has affected Kanaka Maoli here in Hawaii. First, our population was decimated actually by infectious diseases. And I have some examples up on the screen. So that between 1778 and 1883, or 93, excuse me, when the US occupied Hawaii, the population dwindled from approximately 800,000 to about 40,000 native people. And for the first time in their own homeland, Native Hawaiians were outnumbered by foreigners. Foreigners, including Japanese, Portuguese, Americans, and others, were 50,000 approximately. There was a drastic change all of a sudden after the US occupation of Hawaii that altered the health and well-being. Although we were dying off from infectious diseases because we had no natural immunities to these diseases, what happened, although we were gaining our population size, over time we started to become succumb to the chronic diseases or diseases of lifestyle. And I won't spend too much time because I'm not short on time, but this is just to highlight some of the historical things that have happened. So what we do know about one's health, as indicated earlier, is that your social status, your ranking in society, is actually one of the strongest predictors of your health and well-being, whether you're a human or non-human primate, whether you're a chimpanzee or a human, where you lie, where you fall on that structure, your society, determines your health and well-being, how long you will live, how well you will live, right? But that's because there's many factors that are associated with that. And we all know this, so I won't go too much into this. But here in Hawaii, it's been argued that, in the US, that ethnic discrimination is an added burden to many ethnic minorities in the US. John Okamura, a professor at the University of Hawaii, actually has a book out, and he argues that ethnic lines is really along social lines, or vice versa here in Hawaii. And that by design, whether it's by consciously or not, that Native Hawaiian Pacific Islanders and Filipinos are actually at a heavy disadvantage, whether that's in education or business or elsewhere. And this probably goes back to why, although we make up a significant number of the state's population, we don't have the kind of health status that would match that. We're underrepresented in education, we're underrepresented in business, we're underrepresented in politics, we're underrepresented here at the medical school. We have, although 25% of the state's population are Native Hawaiians, less than 5% on average Native Hawaiians enter medical school. So there's discrepancies in society. And what's interesting is, up until now, all the talk about social status and health was really correlational, right? Just observational. But there's a study out of Harvard with women, and the citation's up there. Mendelsohn et al. Was interested in looking at how social status influenced one's health in a short period of time. And so they got these women together, they randomized them to one of two groups. In one group, the women were made to believe they had this high social status in this make-believe world. They created this make-believe activity. And the other group of women were made to believe they had a low social status. And they did this clever social psychology experiment to ensure that every woman in that group did think they had a high social status compared to the others and vice versa. And they followed them over a short period of time, took their blood pressures, asked them about the depression symptoms, and guess what they found? They found that the women who thought they had a low social status, despite their real social status, in this make-believe world, in a matter of a few weeks, had significantly elevated systolic blood pressure and more depression symptoms. Risk factors for heart disease. It was an interesting, it's an experimental study. They controlled for many things. They randomized these women. And the women were just in this make-believe world for a very short period of time. Imagine being in poverty, being a low social status for your entire life. What kind of risk that would place on you, and elevated blood pressure and so forth. And that was a really neat study. You know, I have a whole presentation here about some of the work we've done here in Hawaii around looking at social status, acculturation, discrimination. And to make a long story short, we find that discrimination in Native Hawaiians, whether we're measuring that by self-report and looking at hypertension prevalence or looking at cortisol activity, we see that there's an association between feelings of oppression and discrimination and elevated physiological stress responses. But I want to leave you with something to aspire to, rather than dwell on the bad news and show all the data to support the bad news, because we all know the bad news. I want to talk about possibilities here in Hawaii for a moment. The world that we would like to see in Hawaii and the Pacific and elsewhere. I liken it to the building of a hale. We have the determinants of kanaka health, the na pokihi. Pokihi are the corner posts of a house. So I'm using a Polynesian metaphor to refer to the determinants of Native Hawaiian health, but this could apply anywhere. And there's 4 of them. There's kea'oiwi, or creating a Hawaiian space and place. There is kamalama it's taking care of the environment and our communities. Ka'aipono, healthy living. Kawai'ola is that ultimate expression of all of these things. Kea'oiwi, Hawaiian sense of place and space. If we are to elevate our social status and address our health inequities, we need to address our social status in society. There is no way else to do it. We can throw monies at it. We can put band-aids on the problem. But unless we address our social status, our education, our opportunities, lack thereof, livable wages here in Hawaii, and have a sense of place and purpose, and our aspirations are valued, I would argue that it's very difficult to address health disparities in Native Hawaiians and other populations. So kea'oiwi is creating the opportunity for Kanaka Maori to thrive, to return to the health status of their ancestors. You know, Hawaiian culture, everybody loves Hawaiian culture. You go to any party, there's a luau, they have hula dancers. But a lot of times, our culture is regulated to entertainment, to ceremonies, and that's it. Yeah? It's not everywhere. Oh, yeah, street names are in Hawaiian, place names are in Hawaiian, but that's about it. Yeah? But we need to create a world, we need to go beyond our homestead communities and become part of the larger mainstream, more so. Kamala Ma'aina is about creating healthier communities for our people. Malama'aina, as you all know, means to take care of the land. But aina, you can translate into environment, anything that's in the environment, to take care of. We need to build healthier communities. It's interesting how, if you've ever been to Waianae, how many of you been to Waianae? Because everybody from Hawaii probably been to Waianae. You go Waianae, you guys see sidewalks on the main road over there? Highest pedestrian-related accidents in Waianae. Most of the people in Waianae are Native Hawaiians. That's by design. Imagine how much people you could save in 1 year if you just put up sidewalks. That's by design. That's malama'aina. Ka'aipono, after we achieve kea'oiwi, kamalama'aina, then we can focus on the individual behaviors, lifestyle choices. Now we can ask people to consume better, eat better, whether that's consuming food or man-made products or things from the environment or technology. It's about healthy consumption. It's about living and making the right choices. But we can't do that unless we have kamalama aina, unless we have the opportunity to do so in the right environment and we are valued in that environment, that society values us as a people. And then we can reach Kawai Ola. Kawai Ola is an ultimate expression of health and well-being. I would even argue that Kawai Ola should be that Native Hawaiian culture, values, and aspirations are the mainstream values and aspirations in Hawaii. We are the host culture. They are good values, and we do apply it across everything today. We just don't know it. Now the state are looking at traditional land management use techniques, resource management, traditional Hawaiian ways of doing it. Seems to be working. Value of family, taking care of the aina. These are good values and aspirations, and I would argue that it benefits everyone in Hawaii if we can aspire to that. But unless these things are in place for Kanaka Oiwi, Kanaka Maoli, Native Hawaiians, and other indigenous people in their own homelands, it's going to be very challenging to address the health disparities because they stem from these things. They stem from bad political decisions. It stems from poor and impoverished, obesogenic environments that we live in, which does not allow us to live the life we want to live, so we can't make the right choices. And we'll never reach Kawai Ola. Neither will the rest of society as long as any other group in that society is not doing as well. Everyone in society looks bad. Everyone pays the price for it. So these are just something to think about. And guess what? The federal government agrees with me. They actually released this National Prevention Council Action Plan. These 4 areas that they're asking people to think about in preventing disease. Empowered people, keauoiwi, healthy and safe community environments, kamalama clinical and community preventive service, kaipono, elimination of health disparities, kawai ola. So if the federal government agrees with me, it's about time somebody does. Usually nobody agrees with me, but I'll leave you with those thoughts. Just want to mahalo everyone, mahalo the organizers for this conference. It's a great conference, and mahalo nui.
Make sure I don't mix up the mics. Okay. Thank you, Keave. Another very well-known speaker to at least half of us in the room is my colleague and friend, Dr. Neil Palafox. Dr. Palafox is a principal investigator of the Pacific Center of Excellence in the Elimination of Disparities, works with me in the Department of Family Medicine here at the medical school, but perhaps most importantly has been one of the greatest friends to the Pacific and one of the greatest advocates to reducing health disparities for all of the Pacific Islanders. He is a family physician like myself and a graduate of the medical school here. He worked in the Marshall Islands since 1983 as a National Health Service Corps physician, where he quickly became enchanted, perplexed, and challenged by what was facing the people who were affected by the U.S. nuclear weapons testing program. He's been working with Pacific health disparities for many years and has done a variety of many other things as well. And most recently, in June of 2012, at the last Intercultural Cancer Council Symposium, he was awarded the LaSalle de la Fall Junior Award. And that's for his many years of advocacy, education, research, and many other accomplishments in inspiring others to take on the challenge of reducing health disparities in Pacific Islanders. So it is my great pleasure to welcome Dr. Palafox to the stage.
Thank you very much, everybody, for being here. Firstly, I'd like to say one thing. One of the reasons that this meeting happened is because the Intercultural Cancer Council has decided to really approach all the issues of cancer disparities through a regional approach. And so this is one of the regional meetings. And so when my colleagues who are the, the other regional directors, please stand up, the regional representatives, because there's Black Americans, Native Americans, white Americans that all are part of, the other regions of the United States. And they're here. And the other thing I'd like to say is, Kiavi mentioned that the numbers of Native Hawaiians are going down and or were going down and so forth. So I just like to let you know that my wife and I, who's Native Hawaiian, are working hard to make more Hawaiians. So I'm doing my part. I take my job seriously, Kiavi. So how do I? Okay, thank you. So what I'll be talking about today is health disparities and health equity in the U.S. Associated Pacific, the U.S. affiliated Pacific. And so many of you and many of the students, I just want to give a brief orientation. Many of you are very familiar with this, but some of you are not. When we talk about the U.S. Associated Pacific, what are we talking about? And so what we're talking about is there's flag territories or territories and commonwealths. So the Commonwealth is commonly known as Saipan, or that's the capital of the Commonwealth of Northern Marianas. American Samoa and Guam are territories of the United States, much like the Virgin Islands is a territory, and the Virgin Islands is a territory, and the Puerto Rico is a Commonwealth of the United States. So we're talking about those areas. Also, we're talking about the freely associated states. Federal States of Micronesia, Republic of the Marshall Islands, and Republic of Palau. And many of the people of Hawaii know because there's many, especially Marshalese and Chukis here that you interface with, and there's probably several in the room as well who might be students. So this is the U.S. Associated Pacific. First thing I'd like to note about the U.S. Associated Pacific is the total number in there is 500,000 people. And so one of the things that is constantly told to me is that, the U.S. Associated Pacific, what the hell, doesn't make a difference. There's only 500,000 people. But kind of like Kiavi said, it's very rich cultures. Kosrae, which is one of the Federal States of Micronesia, has 8,000 people. But if we don't take care of Malama, as Kiavi said, here, and to me, that's what matters to me is that these get taken care of. Hawaii is a minority. You're not a minority of minorities. In the recent elections, did anybody, president, come here to campaign? Why? Because we're a small state. How many electoral votes do we have? You're a minority of minorities. And the people within are further minorities of minorities. So this is a map of the area in the Pacific. So this is American Samoa, Hawaii, Marshall Islands, Federal States of Micronesia. This is Commonwealth of Northern Marianas, Republic of Palau, and Guam here. And so this is a vast area. So actually this area covers twice the size of the United States, twice the size. So it's not a small area. And so it creates very difficult logistics to take care of, provide healthcare in this area. Okay, so the objectives, what are we going to try to do here in my short time to talk? One is I kind of take that Kiavi had, Dr. Kohulukula, and I want to look at this as looking at the future. There's many problems now, but if we get stuck there, we get stuck there. I don't want to get stuck there, and that's what hopefully all of the students are about, is your next generation to get us unstuck. So, and then I want to briefly talk about the evidence for the Pacific. The way you move programs and the way that you act depends on what evidence you have. And so I'm going to talk a little bit about that, and you'll see why evidence matters and how you look at evidence and how you think. And then I want to really talk about Pacific solutions through Pacific assets. Oftentimes, Native Hawaiians, Pacific Islanders, they're always analyzed from a deficits model. What's wrong with you guys? You Micronesians, you Chukis, you Hawaiians. It's always like that. Nobody ever really celebrates the assets. The assets are the key to solving the problem, and I think that whatever solutions there are has to be celebrating the Pacific assets. So first of all, in disparities, when we talk about disparities, if I were to ask everybody in this room what is disparities, I bet you some people can't even define it. So first, with my academic hat on, I just want to share with you what model of disparities I'm looking at so that we have a common ground to discuss, what disparities are. So disparities are lack of parity, disparity, or inequity, lack of equity. And so it's relative always to something else. So in this case, it's Native Hawaiian health versus a larger population. It's Pacific Islander, U.S. Associated Pacific Islander health relative to Hawaii, perhaps. It's also, many of you are from the Outer Islands, and Senator Baker and Senator Green were from the Outer Islands as well. And so a lot of people from the Outer Islands will tell you, just like Keawe told you about Waianae, the people from the Outer Islands have worse health care than Honolulu. All of those are true, but those are all disparities. And it falls across many different lines. It can go across men, women, older, younger. It can go across color. And so that's what disparities are, and that's a definition I'm working on. The social determinants, when we look at this graph here, disparities is a description of what it is. The cause of disparities is social determinants. And the social determinants, Keawe touched on them. Poverty, education, environment, and racism. And so they're all the things he discussed. That's the cause of disparities. And within that, one of the things that is important is the concept of structural violence. When you have certain things in place, they cause particular groups not to be able to get ahead. The things that you know well, so Keawe mentioned one, no sidewalks in Waianae. But the other things that you know well, before women weren't able to vote, that was a structural violence against women. Blacks cannot vote. That was a structural violence against blacks. There are many structural violence, there's a lot of structures that are violent within the Pacific. Thank you. Others I can't talk. And that is, one, and social determinants of cause are power and choice gradients. And a lot of you think, racism, is there really racism that exists? Let me just put this out here. I'm trying to make trouble. How many people in Hawaii, whether you're Native Hawaiian or Filipino or whatever, look at a Micronesian and go, you mix. You dirty mix. Think about that. That's not the active racism hanging people, but it's an attitude. And I can tell you it's in the setting of the medical school, cancer research center, all over. And in hospitals, there's doctors who don't want to deal with Micronesians. So my point is, if everybody thinks this is a neutral thing, it's not. And we have to understand that that is part of what we are trying to work with and work against, perhaps. And one of the things about the social determinants, and this is heresy, and you probably all hate it, especially because we're standing in the Cancer Research Center, and because the medical school behind you is there. But did you realize that if all the medical programs, the hospitals, the clinics, all the doctors, primary care, all work perfectly, that it would only make a 10% difference in healthcare outcomes, 10%. All the rest is driven by poverty, education, environment, and racism. Everything else. So as we walk through this, I want you to be that, I'm not trying to drive anyone away from healthcare, but it's one that you take that base and you understand that base, but you have to understand that there's dimensions out there that we have to be comfortable with. And Keawe talked about many of them. And the last thing so we talked about distribution and cause. And the last part of disparity is talking about the action we have to take. The action we have to take is about social justice. A lot of people are uncomfortable with that. Social justice means that you have to have the lens and believe in disparity. It means you take an action to make parity. It is a difficult proposition. You have to make Micronesians, Black Americans, Hawaiians look like the majority population. That's what social justice is. And it's your job to do that through whatever you're doing. That is the action part. So you can't talk about disparities without understanding the description, the cause, and the action, what it takes to change this. It is all about putting those sidewalks in Waianae, and that takes a little bit of social justice. So when we envision the Pacific and envision the future, what I want to talk to you about, this conference really is about international health as well as um, international, local, and national health, because we have countries that are freely associated. They're actually sovereign nations. Republic of the Marshall Islands, Palau and Fair States of Migrant are actually sovereign nations. They're out in a distance, and they are actually, part of an international environment. Then you have the territories and so forth, which are part of the country and associated that way. But we have many people here from that are partners from the nation, the rest of the United States. So this is a conference that talks and truly is about international, national, domestic healthcare disparities. And it's about all of it, and it plays out right in this room. And so one of the things about when you look at global health and the way that it is evolving, one of the things that you see is that, or that I understand, is the Pacific, U.S. Associated Pacific is really the sentinel site for disparities in healthcare. When you look across the Pacific, did you know that for obesity rates, the first 5 countries in the world that have highest obesity rates are all in the U.S., all in the Pacific. 3 of those are in the U.S. Associated Pacific that have the highest obesity rates in the world. Now, I believe that the native Hawaiians would be part of that. But you know what? They're not a separate country, so they're not analyzed like that. But it's just one of these things that says, if you want the sentinel site to know what happens to small populations, when you go into a global economy, that's how you tell what's going to happen. But it also will tell you what's going to happen to the United States, because the obesity epidemic is moving in the United States. It's unfortunately moving quicker in the Pacific. So all the effects that you see, the inability to develop, the cost of it, in Native Hawaiians and in Pacific Islanders, it plays out in the sentinel sites of the Pacific. The other sentinel site is, as you may not realize, is global warming. A lot of the taro fields and so forth in Chuk and other places are flooding. You can't grow taro, you're going to eat processed foods. You eat processed foods, you get more diabetes. And so a lot of things that we do in the United States to raise the tide causes damage out there. And so, again, it's a sentinel site of what the U.S. also is doing that affects other countries in the Pacific. Now, one of the things that I want to talk to you about the U.S. affiliated Pacific is it's really on the edge of the United States. It's sort of part, not really. So this is the definition of disparities. You will see how the territories, the Commonwealth, and the Free Associated States are kind of treated like the United States, but not really. You're sort of wanted as part of the family for particular political reasons, but you know what? We're only going to give you part of the goods, and I'll show you how that is true. And so when you look at the U.S. Associated Pacific, it really is, you'll see disparities in action within the United States. And then I want to just mention that because of this and the new paradigms that we're working with regionalism, understanding cultural assets, and community participation as a way out of this dilemma. So one of the things about evidence, and many of you are budging. You are developing medical students and nursing students and other professionals, and some of you are full-on professionals. But one of the things about the evidence that we use when we try to affect our communities, we have to really realize what that evidence is. And so much of the evidence used is evidence and thought processes used by majority populations. The entire system where we learn in science, which you have been all taught in, that I have been taught in, is the Descartesian model of reductionism. It means you take things apart. Pacific Islanders, Native Hawaiians, don't start with the reductionism, what's wrong here, and then you try to figure it out from the smallest part. They start from the whole. What's wrong with the community? What's wrong with our thinking? Not what is this molecule. It's a very different way of thinking. And so the answers that you get from US and Cartesian types of analysis will give you Western paradigms, Western models, Western science. I conjecture that you cannot solve a lot of other cultural problems by using that way of thinking, because that's not how they're set up. That's not how they think. That's not how they operate. And so it's understanding there are other models of science which are equally valuable that we must uncover and realize if we are going to take care of the disparities. And one of the things, just by way of statistics, is that Hawaii, the U.S. Associated Pacific, Outer Islands, Native Hawaiians, we are all analyzed in statistical models. But you know what statistical models aren't built for? They're not built for small populations. They're built for large populations so you can see trends. So when people say, I can't see the trend in Chuk, the Native Hawaiians, the trend's not quite there. You know what? Statistics, that US statistics thing, is not built for big populations. It actually isn't robust for any statistics that you try to analyze small numbers. It doesn't work very well. So again, even looking at the way that certain models are built, that we have to understand that some of our statistical models and science aren't built for what we're trying to solve. The edge of the United States. And so here's a definition of disparity. In the United States, including Hawaii, we spend, actually this number is over $8,000 per person per year per capita. Now the edge of the United States is the rest of the Pacific. And so look at and these are all US. So they get $140 per person per year in Chuk. They get, $519 in CNMI, and Federal States of Micronesia in total is $373. So that's the definition of disparities. So if you ever want to ask yourself, why do all the Chukis and Marshallese come here? Look at this. What do you expect to build? For $140 per person per year, what kind of health system are you going to build? So why do they come here? And you know who was supposed to take care of that? It was the majority population. It was the United States. That was our promise to them. And so you can see this is disparities and how it works out in here. So it's one of when your friends say, those mix, they're always in the park over there, they're in the homeless shelter. They're just crowding up the place. They're taking up all the jail space and so forth. You know what? That's true, but understand why. And so, again, we talked about a little bit of this, but all the different types of non-communicable disease and cancer is certainly at, very epidemic rates in the Pacific. And in fact, tobacco, adolescents in the Commonwealth and Northern Mariana was the highest in the United States, tobacco smoking rates. So you can see that, what happens in the disparate areas. This is another picture I want to show you of disparities. This is from Ibai Island. Ibai Island is an island that is in the Marshall Islands that is next to a military base. So on the military base, they have a golf course, they have a couple of swimming pools. I've been there, played, they have tennis courts. The people who work there, the Marshallees, cannot live there. They don't even you see those buckets? They have to go to the military base oftentimes to get enough potable water. This is the edge of the United States. Military base, they want us because of the military benefit. Do they treat them like part of the US? I mean, this will tell you probably some of the story, and you saw the graph before. This is the other thing from a policy standpoint, very much from a policy standpoint. When the United States wanted to test its nuclear weapons, initially they tested a few underground in Nevada, but 80% of it was tested above the ground in the Marshall Islands. In the Marshall Islands. And it was tested on places that were inhabited. Why? Because they didn't want the people of the United States to suffer. So they go out to find someplace else. Well, where can we test that doesn't count? Well, it's maybe out here. And just to show you how much we tested over 12 years an equivalent of 7,200 Hiroshima bombs. The US testing kind of in the US, but not really, but on a people who in my mind, they said, we can move them from their homes. And this story in of itself is a long story. So globalization, I'll skip that slide. What did not work in the resource limited settings? So the reason that we have to think differently as we solve these health problems is the United States gave the compact nations dialysis and the territories, pap smears, cervical cancer vaccine implementation, hospital-based care, illness-based care. You know what? None of this worked well. In fact, some of it made things worse. In fact, hospital-based care and illness-based care, the United States can't even afford. The continental United States, that's why we're changing the paradigms. So how do you expect small countries to adjust to that? So the models we gave them, and the dialysis, I was in the Marshall Islands, and I had to take the responsibility of closing the dialysis unit. Why? It ran out of supplies, didn't have enough things to work with. They weren't, some of the people weren't trained enough. So we actually had to close it. So people died, from kidney failure, and they were expecting the dialysis machines to recover. So one of the things about the dialysis units is, why do the people come here to Hawaii for dialysis? This is why. And so again, we talked about global warming, and global warming is a direct effect of the bigger countries. And the one country that is not part of the Copenhagen Accord, which is those countries that have joined the worldwide movement to decrease, water rise, is the United States. It's the United States. And so does it affect the countries in this area, the U.S. Associated Pacific. And by the way, Hawaii is going to get hammered pretty hard by global warming. There was just a conference by the CDC here. And one of the things that is predicted, besides changing in wind patterns and so forth, over time, the wind and wave patterns change. So what happens is that it is very possible, and they're looking at it, because the northeasterly winds no longer will be the predominant winds. You might have your north shore turning into your south shore and vice versa. So if you don't think that's going to have an impact, time to think. So global warming, things like that, is affecting the sentinel site. The Pacific is telling you we're getting flooded. It's flooding our food fields and so forth. It is true that we have it. And so it's a sentinel site that says, Hawaii, pay attention, world, pay attention, because it's coming your way. So we're going to lift the heavy burden together. So what is working? So we showed you a couple of things that don't work. What are the new paradigms? One is things like this. We work regionally. We work partnerships. All the folks in here are from different parts of the United States, different parts of the globe, and we're trying to come together and say, how are we going to work on this problem of disparity, and also to take care of the cancer epidemic? We have formed the Cancer Council of the Pacific. One of the things that the Pacific did, which was actually quite unique, is, how when there's a dengue outbreak or a typhoid outbreak, there's an emergency declaration, and people declare an emergency, then they send in help to go fix that. One of the things that the Pacific Islands, that they said, the biggest emergency is non-communicable diseases. And so they have officially declared an emergency on non-communicable diseases because it mobilizes resources. And so they have, congealed around that idea, and there's a lot of things that are happening right around that, including cancer prevention and control. And they've actually been able to, where they're trying to right now, make all the vertical structures come together. So usually what happens in the models in the United States is the heart programs work like this, and the cancer programs work like this, and the obesity programs are over here. And all the programs are very vertical. HIV programs are over here. But what this declaration did, it said, that's nonsense. You are stopping to do this. Anything that affects non-communicable disease will come together. And they formed at the regional level all over the Pacific a health leadership council to make that happen. So sometimes this very vertical structures can hurt us a lot. Appropriate systems, we talked about this, and one of the things that we've introduced is several technologies that were old but are now coming back that are actually being used in the Pacific. So pap smears, and one of the things, actually the Pacific and the rest of the world is on the edge of, further than the United States. I hate to tell the women in this room this, but pap smears are on their way out. In the next several years, they're on their way out. The reason is it takes too many steps and it costs too much. And the yield, there's better older technologies that have almost a better yield and are single, you do it all at once. You don't have the woman come back. You don't have to send the slide to a pathologist and all of that. And so it's one of these things that breaking news is over time, pap smears are a thing of the history. Where is it being put back in the U.S. Associated Pacific? Again, it's a sentinel site of how do you get better technology into certain places that's actually cheaper and more effective. And then, of course, the advent of traditional medicine. So this is an organization that I wanted to talk about. So, and this, I believe, is second to last slide. So in the Pacific, the cancer programs are organized like this. So each of these areas, Palau, RMI, Guam, CNMI, American Samoa, all these areas, each of them has a comprehensive cancer plan. They also have a non-communicable disease plan. The regional body that is here in this room and many of the coordinators from these also have a Cancer Council Pacific also has a cancer prevention plan that involves all of the things in this area, and they also are working in the risk factor, decreasing risk factors for all NCDs. So this is the way that it's organized. It took 11 years to develop, but it's the way that it's moving forward. And these are all the partners, including everybody in this room. So structural violence, we talked about that. So one of the first things I'm going to ask you and let you know is the Compact of Free Association, which governs some of the compact nations, in my mind, is structural violence. It hurts Hawaii. It hurts, the people there. And so when you hear about this and all the things that are happening, one of the things that causes this structural violence is a treaty that's not working real well. And it's done largely for military purposes. The Affordable Care Act, a lot of people think, oh, that's going to save the day. Well, a lot of it actually doesn't apply to the U.S. Associated Pacific. It's handled in a very different way. Are they part of the U.S.? Are they not? Well, maybe not. So, and in fact, a lot of the areas don't have Medicare, Medicaid, and so on. So managing change, envisioning the future, I think the things that we have to look at are the political support. So I thank all the senators and other folks from Hawaii that were here to say we're pitching in for this, because they're the ones who are going to turn the tide on many of the social determinants. Things that the medical field can't possibly turn, they can actually turn. Partnerships, organizational capacity, communication, and really I want to try to sell this point if nothing else. There's many types of evidence. The way that the Polynesians sailed the ocean, they could sail from point to point without compasses, any of that, and they could sail there under cloud cover. That is a science that has almost been lost. They're trying to recover it. So how did they do that? It's because they're smart people. They have a science we don't understand. And I think we need to go back and kind of understand some of those things to make things different. So that's my spiel. And the last thing is something that Charles Darwin said. It is not the strongest of species that survive, nor the most intelligent. It is the ones that are the most adaptable to change. So we have to change our way of thinking, acting, doing business in order to survive. And I would say, if you look at the path of NCDs, if you don't, we're all in trouble. Thank you very much.
Thank you. Sorry, tech confusion here. Okay, thank you very much, Dr. Palafox. Our next speaker for this opening panel, you heard briefly from earlier, and we're very honored to have her here and clear her schedule to be with us this entire afternoon. Senator Rosalind Baker is a cancer survivor, as she mentioned. She's also a very, very strong healthcare advocate, and she's received the National Distinguished Advocacy Award, which is the most prestigious honor bestowed by the American Cancer Society Cancer Action Network in recognition of her years of commitment to strong public health and tobacco control policies. The annual award is given by the network, the advocacy affiliate of the American Cancer Society, to selected lawmakers who demonstrate solid, consistent leadership in the area of cancer-related public policy advocacy. Her work on public health and tobacco control policy was also recognized in 2007 with the Exemplary State Elected Official Comprehensive Cancer Control Leadership Award given by Sea Change, and the president of Sea Change is here. But Senator Baker won that, and it was presented by then President and Mrs. George H.W. Bush. So again, I'd like to bring to the podium Senator Rosalind Baker. Okay, let me put this on. This is the...
Okay. Can I just do it with that? Okay. I'm not Italian, but I tend to talk with my hands. So I'm feeling a little technology challenged at the moment because unfortunately I needed my notes so that I can stay within the time frame. And so I was afraid I was going to have to hold a microphone, my notes, and the pointer, but we'll see. I invite you to bear with me this afternoon. Aloha awinala kako. It's good afternoon, everyone. It's my pleasure to be part of this. Mahalo for inviting me to share with you some of the policies that Hawaii has put into place to help reduce health disparities here, as well as some of the other ones that we are working to enact, need to be enacted, and then need to be funded in order to further reduce the health disparities and improve population health here in our islands. Now, the two speakers that have preceded me have certainly excellently described the challenges in the landscape. My premise is that without a number of policy initiatives over the years, the landscape would be much more challenging, while acknowledging that we still have a lot more to do. I'll try to outline some of those policies, discuss the others that are now in place or under consideration and that need to be implemented. All right. Am I doing it? Yes. Okay. 1974 was really a seminal year for health policy in Hawaii. This was the year that we enacted our Hawaii Prepaid Healthcare Act, which almost brought universal health insurance coverage to everybody in the state, because Hawaii enacted an employer mandate requiring all private employers to provide health insurance to all full-time employees. Our insurance coverage went from 70% to 95% upon implementation. It was a very good thing and withstood court challenges. But since that time, the number of uninsured has crept up. The recession, poor economy, increased unemployment, shift by employers to more part-time workers because the cost of insurance was going up, the lack of sufficient state resources to address all of the societal needs, healthcare inflation, shortage of professionals in our healthcare workforce, all have contributed to inequities in access to care and a worsening of health disparities in our state. Now, we still have a relatively low number of uninsured in our state, between 10, 11%, depending on when you actually track it. It's less than any other state except Massachusetts. But for a state that prides itself on being the health state, second place just isn't good enough. Let's take a little closer look at the profile of the uninsured. People that report not having insurance are more likely to come from a low household income. They're more likely to be unemployed or underemployed, and probably have less than a college education. And oh yes, they might also be Native Hawaiian and or reside in some of the more rural areas of the counties of Hawaii, Kauai, and Maui. These folks might include low-wage earners, those with low educational attainment, immigrants, Native Hawaiians, as well as those disadvantaged by long distances to health services or lack of culturally sensitive healthcare providers. The next foundational policy, although I know that there are some challenges here and it may not end up offering all of its promise, but I think it offers the hope for universal health insurance coverage and ultimately health coverage in Hawaii when we take it in concert and in tandem with Hawaii's Prepaid Health Act. It provides some important elements. Subsidized insurance for people who cannot afford health insurance and don't have it through their employer. Expanded Medicaid coverage so that we can make sure that we're covering everybody that would otherwise be eligible for state insurance. There's a focus on prevention. We need to get people earlier in for diagnosis and treatment because it will save us money and heartache and all kinds of burdens on society and the individuals with those conditions. And also, to me, this is, as a cancer survivor and someone with friends who have chronic diseases, this is very important. No longer, when the Affordable Care Act is fully implemented, no longer will insurers be able to not cover pre-existing illnesses. We know that we have a very mobile population. People move from place to place, they move from company to company, and their insurance needs may change. I think that these opportunities for healthcare coverage and insurance give us an opportunity to improve the health status of our residents. But like everything else, the devil is in the details. The two foundational policies give us an opportunity to look at some of the social determinants of health and focus on specific policies and outcome to improve the health status of 80 to 90% of the population at risk for chronic disease, because it will help us tackle smoking, poor nutrition, lack of physical exercise. Let me explain each of these areas in light of some of the policies that the Department of Health and the legislature have sought to enact, positively impacting health outcomes for members of the disparate populations. And if you haven't seen, there's a wonderful booklet that has a lot of the same information I'm providing you, because I liberally borrowed it from the Department of Health's 2011 Chronic Disease Disparity Report. And I saw one of my coalition colleagues bringing copies in when I checked in this afternoon. Individual choices not to smoke or to eat healthy food are really constrained by income, educational attainment, or living circumstances, as well as chronic social stressors. If we don't take some of these social determinants of health into account, we're not going to come up with the appropriate strategies that will enable us to address these chronic conditions. And I think all of us know chronic diseases are the most costly, most prevalent, and most disabling of all the diseases. The other thing that the social determinants of health point out is the need for community-based, comprehensive, integrated approaches. And I think it's important that we acknowledge these determinants and then continue to focus on health disparities, acknowledging that it's going to take political will. I guess that's part of why I'm on this panel, and integrated approaches. I thought this quotation from one of the other items I was doing research in particularly telling. Mortality is strongly patterned by key social characteristics and prevalent health risk factors, and underscores the need for health policy and clinical interventions focusing on those social determinants of health, especially ones that focus on income security, smoking, both prevention and cessation, and physical activity. In Hawaii, the Big C is the second leading cause of death. Each year, nearly 6,000 people throughout the islands are diagnosed with cancer, and more than 2,000 die from the disease. Nearly 2/3 of all the cancer deaths in Hawaii can be linked to tobacco use, poor diet, obesity, and lack of physical exercise. These are factors we can control. We can do something about them. And I believe with appropriate policies in place and implemented, we can help change those factors and improve health in our islands. Let's talk about smoking, one of my favorite topics. Our anti-smoking strategy is really three-pronged. First, we wanted to change the social norms about smoking. We really wanted to put into effect policies that would make smoking unacceptable from a social standpoint, that would be inconvenient. And so we set about gearing up with a lot of local grassroots effort to enact comprehensive smoke-free laws. We were successful with Act 295, Session Laws of Hawaii, 2006. In addition to trying to change the social norms, we wanted to make smoking an expensive habit. We know that many adults start smoking when they're young people. Young people are very price sensitive to the cost of tobacco and cigarettes, so that's a good thing. If we can raise the excise tax on tobacco products, cigarettes, and others, we have a good shot at keeping people from starting and maybe providing a financial incentive to quit. We also want to make sure that we help smokers quit for good. We know that if you're a smoker, it probably is going to take you several times to quit, maybe a whole lot of several times to quit. But if we have good backup, if we have good quit line, if we have good counseling, if we use all of the best tools available to us, and get them into the areas where smoking it continues to be a problem, we have an opportunity to make a real dent in helping improve somebody's health. A peer-reviewed paper that was recently published in the American Journal of Public Health notes that if tobacco control policies had remained at 2002 levels rather than increasing, the prevalence of smoking and established smoking would have been roughly 10% higher in 2008 than actual levels. See, policy does actually impact tobacco use. November 16th, 2006, the date of the Great American Smokeout, the Hawaii Comprehensive Smoke-Free Law took effect, and we were ready with some new signage. It was landmark legislation because it provided a consistent level of protection for workers and others that would not have been possible without dedicated individual coalitions and others in our counties that lobbied first for local laws to prohibit smoking in bars and restaurants. We started small and got bigger. I don't think Act 295 would have been possible without engaging many community partners to stand up with the anti-smoking advocates. We had to reach out into all parts of our community to get buy-in. We had bar owners talking about how happy their employees were to work in a smoke-free workplace and how pleasant it was not to smell like a stale, overflowing ashtray at the end of the night. Customers appreciated it too and began to go to those establishments that had gone voluntarily smoke-free. And small business owners could honestly tell legislators that going smoke-free had not hurt their businesses, but going smoke-free had actually helped them. We had support from the American Cancer Society to fund market research and public opinion polls to help some skittish lawmakers vote yes. Now, the first grassroots effort probably started in our schools with what was the class, the elementary school students, going to be the class of 2000. They took a pledge to remain smoke-free. They bugged their parents to quit. There was a lot of bad publicity around this particular time from the Surgeon General and others talking about the harmful effects of smoking. And we saw those wonderful warning labels put on the packages. Some establishments, as I said, began to voluntarily act. They created first non-smoking sections or began to prohibit smoking on their own. But we know that just saying that, okay, this half of the room is not going to be smoking and this half can smoke doesn't really work. It took a concerted grassroots effort to create change, and our effort reached into all corners of Hawaii. Collaboration to raise awareness and diverse advocates for a tobacco-free Hawaii were really the keys. So when Senate Bill 3262 came up for final passage, only 6 members out of a total of 76 legislators voted against Hawaii's new comprehensive smoke-free law. It's not a perfect law, but it was such an important step forward for tobacco control in Hawaii. You know, our efforts in Hawaii, I think, could be heralded as a great public health success. We've reduced smoking. We've reduced the exposure to secondhand smoke. We have folks who smoke that are trying more and more often to quit, and fewer cigarettes are being smoked. So what was it that worked? Our policy changes, bans on indoor smoking, increased cigarette taxes. Our tax on a pack of cigarettes is $3.20. We're one of the highest in the nation, but it may be time for us to amp that up shortly. We're also trying to make sure that we up the taxes on other tobacco products because we don't want people to go from an expensive cigarette to a cheap chewing tobacco because the problems are just as bad and cancers still get created. We've also provided kinds of clinical innovations or interventions rather, as well as our quit line and programs that are targeted to specific populations. Now, because we still have smoking in some of those targeted populations, we still have work to do, but we've directed our mass media campaigns, our quit line, and web-based activities in order to try to reach out to the folks that still smoke. Unfortunately, there's a downside to success. Our policies and strategies haven't impacted all of Hawaii's people equally. We need to look at other more appropriate ways to help Native Hawaiians, those with low educational achievement, those in low socioeconomic stratas in our community, those living in rural areas. We need to continue to help them to try to succeed in kicking the tobacco habit. You can see a visual representation. I want to say mahalo to Lila Johnson for sharing a presentation that she did to our Tobacco Free Coalition in 2011, because I found some of her slides so informative that I copied and pasted them. Why recreate the wheel when somebody else has already done it for you? This just indicates how the kinds of the social determinants of health are abundantly available in the population that's smoking. We know that poverty and chronic stress can constrain people's ability to make healthy choices or to change behavior. If we look at and tease out really the nuances of how social determinants and social factors, as well as stigma, lead to the continuation of tobacco disparities in our community, I think this will be very telling on how we will know how to target prevention and control efforts in the next few years to come. Staying on the tobacco theme, you can see that we have geographic disparities, with Hawaii Island, Hawaii County having one of the highest, and Kauai edging them out by 0.8%. And then the other geographic distribution of our smokers. If you really look at where within the geographic areas they're in the areas with lowest education, lowest incomes, and rural areas, less access. Here's the education slide. We've had persistence in the pattern for high school, for high smoking rates among those with the lowest education. Hawaii smokers, 30% of them have less than a high school education, 22% a high school education, 16% some college, and 12% college educated. So it's really annoying when I see health professionals smoking. Here's the, I think my slides were slightly backwards. So what I had showed you before had to do with income, same kind of deal. If you have lower income, you have higher smoking. This is the education statistics that we went over, and here is, okay, I am a little backwards, sorry about that. There's income. It shows that higher smoking, the less income you have, and with the cost of our rates going up, some would say, well, we're being worse on the poor, but we need to provide them with that financial incentive. This just shows the employment status and how that impacts. So all of the things that you've heard before. We want to make sure that we can stop tobacco product use in our youth, because we'll save lives and billions of dollars, but we have to be vigilant. And this is just an indication of how big tobacco is really trying to make it more attractive and less expensive for folks to buy tobacco products, and we have a bill in the legislature to create parity amongst those. Just when you think you're out of the woods, you've got your smoke-free law, along comes e-cigarettes. Big tobacco companies are buying up and investing in e-cigarette companies in an attempt to keep people hooked and puffing on something with new flavors designed to appeal to youth. This is just one of the ads. You can get them on the internet. Kiosks are popping up all over the place. And we're working to try to get ahead of this curve to make sure that they cannot sell them to our youth and that they're taxed just as highly as anything else. The other area that we need to address is poor nutrition. And these are some of the policies and programs we put into place to try to do that. Allowing the use of electronic benefit transfers, the old food stamps at farmers markets, so people have an opportunity to get more fruits and vegetables, fresh fruits. We're looking at school gardens. We've seen more and more of those prop up in our communities and also with our FQHCs. We have a bill, Senate Bill 564, that's really going to help to put a farm-to-school program together. We allow only water in our vending machines in schools. We are partnering with farmers for fresh fruit snacks at schools. We have more salad bars and better offerings in our cafeteria. But one of the things we haven't been able to do yet, we need more grassroots support, is to get a sugar-sweetened beverage tax enacted. But we're working on that. And I know with leadership at the Department of Health and my good friend Dilip, we'll get that eventually. The other area that we are trying to work on is increased physical activity. You know, policies can have negative as well as positive effects. And when we took physical education out of our schools, that was a very negative effect. So now we're racing around trying to figure out how can we do a better job of getting our kids to move. The Lieutenant Governor just yesterday announced a new initiative after school to really provide some of these enrichment programs, whether it's hula or other kinds of activities that will get kids up and moving and really help make up for some of the things we've taken out of school. We all need to follow the First Lady's example and get up from behind the computers, put down our laptops and our iPads and whatever and move. We even need to do this in our workplace. I've tried standing up at the Capitol and typing on the computer to see if that wouldn't be a way to maybe burn a few extra calories, because I promise you, I sit down way too much on this job. We've also seen efforts at the county and local level to create planning activities around livable, walkable communities. That's been the effort to try to get more sidewalks, to make sure that our planning and land use processes are aligned with what would actually make it easier for people to walk, to bicycle, and to get some exercise. One thing I just need to call to your attention in terms of encouraging workplace wellness, because it's kind of funny, I think. Senate Bill 1337 clarifies that incentives to reach healthcare and fitness goals are not considered gambling. We have some very strict gambling, anti-gambling and gaming laws on our books, and people were saying, because it contains the phrase something of value, that people were afraid if HMSA, Kaiser, or some other insurance plan or a company would offer, you know, if you meet your fitness goals or you meet your healthcare goals, you know, we're going to take $10 off of your health premium, or we're going to give you a vacation to Vegas or whatever, that would be considered a lottery and therefore gambling. So not to be daunted, us legislators have put in a bill that's moving through that's going to make sure that that doesn't derail some of our other good policy initiatives. Cancer disparities, I think we all know that with less household income, people are less likely to go and get their screenings. Maybe they don't have screenings as part of their current health plan. Maybe they don't have a health plan. But we notice that cervical and breast cancer screening for women, particularly Filipino women, are problematic. Colorectal and prostate cancer screenings are especially problematic for Native Hawaiian and Filipino men. So we've tried to put programs in place and expand on programs that we've gotten funding from the feds to target these high risk and gap groups. So we have an expanded BCCCP program that also provides not just for the screening, but for some treatment. And we're trying to get the legislature to fund a similar screening and treatment program for high risk groups in colorectal. We know that the early detection, these screenings save lives, they make good sense, they save money, they save a lot of heartache and pain for the people that do have cancer, and it's very important that we do this. Our Comp Cancer Coalition is committed to equitable access to care, and that means that we've got to figure out ways to help reduce the financial, geographic, and cultural barrier to appropriate cancer treatment. One of the things that we've put in our strategies is to work on creating Hope Lodge. This is a program of the American Cancer Society. It will enable neighbor island patients needing cancer treatment on Oahu to come to Oahu and stay free of charge. We also want to make sure that we have more use of patient navigators as a reimbursed healthcare service, because many of our folks in the disparate groups need facilitated access to care. Patient navigators are critical for them. We want to improve language access. You know that Hawaii has the greatest percentage of non-English speaking households and people with limited English proficiency in the US. So language access, culturally appropriate strategies are really critical. We want to increase the number of clinical trials. We want to increase the number of cancer patients that have a medical home. And finally, our vision is clear. We want a state with no more cancer. So I kind of like this canoe with all of us in it together. This is our No More Cancer canoe. We're paddling all in the same direction. We're all in the boat together. We're men, women, all kinds of ethnic groups, all kinds of income ages, and we're going to make sure that Hawaii continues to provide accessible, top quality health care for all. We know that there's been a weakening of that standard in recent years, but we also know that health disparities in our community are simply not accessible. As a state whose population ranks second nationally in the number of diverse ethnic groups, more engagement with these groups is needed to identify specific cultural strategies that help reduce cancer risks. Hawaii has a proud community tradition of working to improve the health and well-being of our people. Hawaii's Comprehensive Cancer Control Coalition and our many partners are determined to take the steps needed to discover and implement solutions that reduce Hawaii's death rates from cancer and help eliminate existing health disparities. It will take all of us in the No More Cancer canoe, paddling together, moving forward in the same direction to reach our goals. But I'm confident that we can do it. Imua, mahalo.
Thank you very much, Senator Baker. And we are running a little behind time. It's important that we stay on schedule because we have a full afternoon ahead of us. But if we have, I think, time for maybe just two quick questions for any of our speakers, Senator Baker or Dr. Palafox or Dr. Koholokula. And it's like, two questions. Are you kidding? So what we'll do is we'll take a short break at this time. If I could ask you to be back in 10 minutes. I know, it's supposed to be 15, but it's really important that we stay on schedule. Okay, so let's take a quick 10-minute break and then report back here. Thank you. And to those on the mainland listening, thank you so much for joining us, and we will end our webinar now.